Good morning. Good morning. Welcome to the third meeting of the Health Budget Review Subcommittee on Health and Family Services. There were materials late in the afternoon that were posted on the LRC website. And so those are there. And I guess we'll go ahead. Does anybody have any guests they'd like to recognize? Nope. Okay, great. All right. Go ahead and call the roll, please.
Representative Duval.
Here.
Representative Johnson.
Here.
Representative Raymer.
Here.
Representative Wilner. Representative Wilson. Representative Bowling. Representative Bray. Representative Heverin. Representative Moser. Representative Petrie. Representative Williams.
Here.
Chair Fleming.
Present. Okay, I think we have quorum at the skin of our teeth. And with that, I'd like to go ahead and entertain a motion for the approval of the minutes.
I'll make that motion.
Thank you. Second. Very good. All in favor, say aye.
Aye.
All opposed, say no. Very good. The minute stand is approved. All right. Commissioner Lee, feel free to come on up. And I know you have a, I don't know, 25, 29, 27, 29 slideshow. Once again, I think last time I'd like for you to hit the highlights. We got those late and really haven't digested everything in there. I know you're focused on the program integrity, which I appreciate. But I'd like for you to just to sort of highlight some of the things in there, if you don't mind. And with that, if you raise your right hand, repeat after me, or do you swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Very good. Thank you very much. Okay, well, you have the floor.
Thank you.
Thank you. If you just go ahead and introduce yourself, and you probably know that, and it's a good reminder, so if you don't, go ahead and introduce yourself.
Morning. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
I'm Jennifer Dudinsky. I am the Director for the Division of Program Integrity with the Department for Medicaid Services.
So good morning. Glad to be here to talk about the Medicaid program. As always, this first slide is something that you've already seen, just gives an overview of the program and responsibilities at the state and federal level. Medicaid is a partnership between the state and federal government. We have a federal medical assistance percentage, which is the FMAP. That's the amount of federal dollars that come into the state for the Medicaid program. As you can see, our traditional Medicaid benefits in Kentucky, we receive 71.48%. For the program, the administration is at 50-50. Personnel is also considered administrative, and it is a 50% FMAP. However, nurses are a 75% because they are in medical. They do have a higher FMAP. Our information technology services also has a little bit of a higher FMAP. With our expansion population continuing to receive 90% at the federal of the funding at the federal level. K-CHIP benefits and administration, that's the Kentucky Children's Health Insurance Program, is currently receiving 80.04% of the cost for that program. That includes both benefits and administration from the federal government. And the FMAP, I would like to say, is based on the state's per capita income. The lower your per capita income, the higher your FMAP. So Kentucky is one of those states that does have a pretty low per capita income, so that's why our FMAP was at about 70%. So approximately 1.4 million members on the Medicaid program. Of the 1.1 million children that reside in Kentucky, over half of them are eligible and enrolled in the Medicaid program or the Kentucky Children's Health Insurance Program. We have 485 expansion members. Those are those members between the ages of 18 and 65 that are at or below 138% of the federal poverty level. We have over 69,000 providers that deliver services to our members. And in 2024, our combined expenditures for administrative and benefit services were $18.5 billion. This is just a little organizational structure. As you can see, the Office of the Commissioner, we have 7 different divisions with various tasks underneath the purview of the Commissioner's office that perform various tasks. And today we do have Jennifer with us, who is with the Division of Program Integrity. She is the director and oversees all of those programs. Our Medicaid populations, we currently have 5 managed care organizations delivering services to our Medicaid members. The biggest difference between those Medicaid or the Medicaid managed care population and the fee-for-service population is that fee-for-service population is typically long-term care individuals and individuals who are in our 1915C community-based waivers. They are a little bit more medically fragile than those individuals served by managed care organizations, and the managed care organizations serve about 90% of the Medicaid population. Since we're talking about fraud and abuse or program integrity today, we just wanted to give you the top 20 provider types where the Medicaid funding is spent. As you can see, hospitals account for 26.4% of the expenditures in the program. This is for 2024, with pharmacy, nursing facilities, and other providers following them. So these are the top 20 provider types paid by dollar amount. And then when we get into talking about Medicaid fraud and what we do to combat fraud, identify it, we just wanted to show you the most common types of Medicaid fraud, which billing for services that are not performed, double billing. And as you can see, most of these or all of these in here are more provider-driven. Member fraud accounts for 2% or less of the fraud activity in the Medicaid program. And so with that, I will turn this over to Jennifer and her expertise from the Division of Program Integrity.
And a real quick question before you start. I want to ask the Commissioner, what's the, how many folks do y'all have in that unit, the fraud unit?
We have about around 60 employees total.
60 employees. And the 2% represents what in terms of dollars?
The 2% of, so out of the fraud cases that are typically identified, only 2% of the 100% of fraud and abuse identified in the Medicaid program can be attributed to member fraud and abuse. For example, maybe sharing their card or getting someone else's identity.
So, all right, so 98% basically is a provider or?
Yes.
Okay. Is there any MCO concerns or fraud issues with that?
Do you have that in?
There's, I'm going to talk about the MCOs a little bit in the presentation. But yes, so MCOs have their own individual special investigation units or program integrity units. And so they perform that function within the MCO. And then anything that they do comes to my division. We review all of that work, and then we make determinations on actions that need to be taken, and either work back with the MCO to put those actions into place, or we work to refer those on to law enforcement.
And how successful have you been in terms of maintaining, basically them following through on your recommendations or your concerns?
They follow through with our, we have kind of an ongoing report that we have been tracking for some time on the number of referrals, the number of cases that we track, what they recover from providers. Some of those MCOs have, I guess, a higher success rate than others in terms of cases being successful and being referred on to the Office of Inspector General or the Office of Attorney General. So we do have specific criteria those cases have to meet. And so, as I said, some have more cases that move forward than others. But I would say that we work good collaboratively. We're always working to help educate them. Actually, we have a training scheduled in March, I believe, another training to kind of go over and keep them up to date on, what our expectations are, what trends we're seeing, and things that we expect them to look for.
Okay. Thank you. If you don't mind, just go ahead. And just once again, if you just hit the highlights of some of your deck. Thank you.
So the function of program integrity basically is to provide the program against fraud, waste, and abuse. And that's about by providers as well as members. As the Commissioner stated, the member level is pretty low. And then we do make sure that our providers and members are also in compliance and that we are in compliance with federal and state regulations. The Division of Program Integrity has 4 branches. We have the Provider Licensing and Certification Branch, audits and compliance, recovery, and third-party liability and estate recovery. I'm going to talk through a little bit about each of those. So within provider licensing and certification, we are responsible for timely enrolling both in-state and out-of-state Medicaid providers. And in addition to enrolling them, we have certain things that we have to do within certain time periods. So like providers have to revalidate every 5 years. Also, if they have reinstatements or reapplications, we review all of their information at any time that any of those changes come through. We do have 2 sections within that branch. One is the application review. That team is responsible for processing and screening new providers that have not been in the network previously. Maintenance review is responsible for conducting any other types of business that we have to with providers who are already enrolled. So any type of change to the provider file, be that an ownership change, renewing licensing or certification, updating any information they have, and then the revalidation, which they are required to do every 5 years.
On a technical question, real quick, if you don't mind interrupting, on the changes in ownership, how do you handle that with nonprofits?
With nonprofits, so
Because there's no owner change in nonprofits, and I've been hearing concerns about the oversight of you all in terms of how you're handling the ownerships. Because there's no ownership obviously in a nonprofit. I can understand that when no change in ownerships for profit oriented in terms of 5%, you have to disclose everything. But I don't understand about. Could you explain the ownerships when it comes to the nonprofits and oversight with that?
I might need to see a specific example to kind of research.
You can
what
talk. You're talking
what
to one example right here.
Okay. So with our change of ownership, it's basically a process that would be the same for any type of provider. It's a matter of reporting that information through our portal. So we do have a provider portal. Providers access, or they might have credentialing agents that go in and enter that information. And so it's just a matter of showing what that ownership information is, or the board of directors, or
And that
sort of
requires Social Security
information.
numbers from all the board directors of non.
We do require Social Security numbers being reported. I know we've had some concerns about that in the past. I would have to
I
revisit.
have a concern about that too, because that's a problem.
Okay. That may be something that maybe we need to discuss
I appreciate it. Thank you.
offline. I'd be happy to discuss it with you.
Okay.
Okay. So we do perform a number of different checks on providers during the enrollment process to ensure that we are bringing good providers into our network. So the Death Master File, OIG exclusion list, of course, we don't want to let anybody in who's been excluded, Medicare revocations, any other state that has issued a termination for a provider, we look at that. We look at Kentucky terminations because oftentimes providers will terminate and try to come back in later. Payment suspensions, accounts receivable, well, I'll talk about those later on. We do site reviews on certain providers who are high-risk providers. We do require fingerprint background checks for some providers. And again, the risk review kind of dictates that on where they fall as far as a high-risk provider versus a low-risk one. So for terminations, because provider enrollment also, as we enroll providers, we are in charge of terminating providers as well. So some reasons for terminations are incorrect information being provided at the time of application. We find information out that would result in us wanting to terminate a provider. Failure to refuse or pay an imposed penalty or follow through with a settlement agreement, any conviction through the judicial process, a termination from Medicare or any action by Medicare such as a suspension, revocation, revoking a certification or license. The ownership or controlling interest of the provider has substantially changed and they failed to report that to us. And then also a provider is deemed to have abandoned their provider number if they go 24 consecutive months without providing services, and at that point we would terminate. Just a couple of notes, except for nursing facilities or immediate care facilities, our terminations occur prior to a hearing. And then also we do take into consideration member access to care before we terminate a provider to ensure that members have the opportunity to get services from another provider and we don't take a provider from them that they may need. So the next branch I'm going to talk about is the audits and compliance branch, and this is where most of our auditing and any reviews before we would refer something for a law enforcement investigation. So we do partner with federal and state law enforcement agencies. We work very closely with our Office of the Inspector General. Anything that we deem that's fraud would have to go through their office in order for us to move forward. We also partner with the managed cares. I kind of talked about that at the beginning. And we conduct both pre and post-payment audits. I'll talk a little bit more in depth about the prepayment, but we identify providers to audit based on some in-house data analytics algorithms that we run, looking at high utilization numbers for a specific service code provider. We do look at waiver providers because they are taking care of our most vulnerable population. And we have a number of federally required audits that we must do and report back federally. We handle those in program integrity. We also accept special requests. We also have a unified program integrity contract that is a contractor with Medicare that conducts auditing for Medicare and Medicaid. They identify things for us. They kind of work, if any of you have heard of a recovery audit contractor, they sort of work in that capacity. We also have a partnership with Healthcare Fraud Prevention. They identify algorithms and high utilizers across the nation and report back to each state if they get a high flyer that is a Kentucky provider, and we're able to follow up on that. We get reports from the Office of Inspector General hotline, and then we also just get member fraud and provider complaints just from the public as well. So credible allegations of fraud. Once we, in accordance with 42 CFR 455.23, we must refer a case where there is a credible allegation of fraud to the Kentucky Attorney General. We work closely with the Office of Medicaid Fraud and Abuse Control. Some of you may have heard MAFUCU, the acronym MAFUCU, before. That's at a national level. Medicaid Fraud Control is referred to in that manner. And they are the federally designated entity to investigate and prosecute Medicaid fraud. When we refer a case to the Attorney General's office, they may request a law enforcement exception. That puts a provider on what we refer to as a stand-down list, which means that we don't take any action on that provider until they have either removed that law enforcement exception or they've closed a case. We meet with the Attorney General's office on a monthly basis to review current and pending cases. So we are in active communication with them regularly.
Are you keeping track of what's going on on the federal level when it comes to the fraud and abuses, and they're trying to cut down? And what plans are you anticipating going to be employed in order to do the oversight of that? Okay.
I'm sorry, what plans do we have?
What are you, given the movement, and there's a lot of
Right.
moving parts on the federal level. And one of those parts that are moving is they're looking at fraud and abuse
Right.
and so forth. And apparently they're coming up with a significant number of issues and problems and dollar amounts. What are you doing in terms of anticipating what that might be coming down the pipe in order to put us in a position to embrace what they might be doing?
Sure.
And then going from there.
So, we follow trends, of course, that are happening on a federal level in terms of fraud and abuse. And so we stay up to date and current on what is occurring in other states and try to keep a handle on that as far as looking for what the trends are in fraud, waste, and abuse. In terms of, where we might be moving, we have I feel like we have a very lean staff who operates very efficiently and effectively. We work to be in compliance with the federal regulations. We work closely with our CMS partners, with our HHS OIG partners. We are in regular communication with CMS and with HHS OIG. And they are on meetings with us pretty much on a monthly basis. At least we're in touch with them, so we are aware of what expectations are. We are constantly looking for trends and ways to protect the program. I think we've been very successful. You'll see some numbers later in terms of what we recover, in terms of not having a huge amount of fraud in the state because we try to prevent fraud on the front end as much as possible. We try to not let providers into the network that we have concerns about and that we don't want caring for the population that we serve.
I know the Representative Johnson has a question. Before I turn over to him, I want to ask you. You keep on mentioning trends, which is good to hear. But the commissioner mentioned. Thank you. The commissioner mentioned. We've got a couple CPT codes that are way out of the benchmarks.
Yes.
What did you do to look at monitoring that trend over the past year in order to curtail that? And then notify the commissioner as well as the General Assembly in terms of trying to control that, because that's an increase in the cost.
Yeah, so that's a collaborative effort between my division and other divisions within the department. So we are still currently working on a lot of drilling down into those codes, looking at the providers who are utilizing specific codes, how they're being used, doing some auditing. So when we audit in program integrity, we're requesting records, we're reviewing them to make sure that the appropriate codes are being billed, that the provider has the appropriate documentation. So it is a lengthy process. So we are still, we still are working on those things. In addition to that, we work closely with policy to make sure that we have policies that are appropriate for what those codes are. Right now, there's a trend with a lot of concern on behavioral health services. So we work closely with our behavioral health team as well on the providers in that network, the codes that they're billing. So, it's not just that that's happening in one area of Medicaid. There are numerous areas within Medicaid that's looking at it and trying to make sure that our program is protected and
you're
taking
aware about
actions.
some of those PT codes getting out of whack?
Yes.
You're aware of that?
So we do, as I mentioned at the beginning, we do a lot of data analytics. So we're constantly looking for like the high use codes, which providers are billing those codes. We look at it at a number of different angles. So we're looking at the codes itself, the services. We're looking at the providers who are billing that. And even within that, it can be very complicated when you've got multiple providers within a group practice and you have to drill down into the individual providers in the practice who may be utilizing codes more than others. So it's a complex process. And it does take a lengthy amount of time to go through all of that. But yes, we are aware of it, and we proactively do everything we can to identify and then put measures in place to prevent it from happening in the future.
Okay. If you don't mind, I know you're maybe a little bit halfway through. I do want to, because we got some time, but then again, I want to cover some other topics beside the program entirety. Representative Williams is first. Sorry.
Thank you, Mr. Chairman. I just had a quick question. You may go into the presentation, but I got another committee, and I was afraid that I'd miss it. But how many people have been prosecuted for fraud against Medicaid?
I don't have that exact number in front of me. If I can certainly get that for you, if
Okay.
you want specific like spans of time, I'm happy to get
If you
that
could do
for you. 'Cause
maybe the
we can
last 5
capture it.
years, maybe
Last 5 years?
Yeah.
Okay.
I wouldn't think it's a ton, a
It's
large
not,
number,
not
but
I can tell you, like last year, so we had about 62 terminations last year.
Okay.
And of those, we may have had, it might look on paper like it was multiple, but it was providers, it was about 2 or 3 providers. It looks like it's more than that because of the way the charges are. But
Okay.
it would be about like 2 or 3 in that past year. But I'm happy to get those numbers for you.
and that's above termination. I meant like actual prosecution.
Yes, well, if we would process the termination if somebody were convicted.
I see, okay.
So that's how I knew
Okay.
that.
Thank you.
And when you report back, would you mind just give it to the staff and then they'll just disseminate it out? I appreciate that. Representative Johnson?
Thank you, Mr. Chairman. Thank you for the presentation today. It's great. You mentioned meeting monthly with the AG's office to go over cases. Ballpark, and just a typical number, how many cases in any given month are we talking? 10, 100, 1,000?
Oh, sure. So the monthly meetings that we have with them are basically set up to go over the pending cases that we have that we are going to refer to them to see if they're going to accept them. And so I would say on average, there might be 2 a month that we refer. Now, that's different than what their caseload is, of course. You know, they have a number of cases open that I would have to go back and look at, but we get a listing, a report that lists all of the cases that they're working on every month, which gives us some details about those cases.
Great. And if you get a chance and you want to just shoot me an email on what the caseload looks like,
Okay.
typically, I'd appreciate it.
You're talking about from the Mfuku, like what
Yeah.
they're, okay.
Thank you, Mr. Chairman.
You're welcome. Go ahead, Director. If you don't mind, just spend another 5 minutes. If you don't, so we
Okay.
can go through get some other topics. I appreciate it.
Okay, so we've talked a lot about the fraud investigations. I've kind of talked about the process that we make those referrals. Sometimes, though, the referrals do initiate with the Attorney General or possibly the U.S. Attorney's Office, and we're made aware of those, and we treat those as provider stand-downs. But really, we're kind of hands-off at that point, other than providing data, providing policy clarifications and information to them, or testifying if they need us to testify. And we don't have any control over the length of time of those investigations.
And I think that last bullet on this slide is very important, that Medicaid, the Medicaid agency itself has no control over how long a case may take and whether that case is prosecuted or not. We just simply provide the information for investigation.
So just to kind of move things along, basically this slide is just to tell you we are required to do audits in accordance with the Social Security Act, and we do audits on any provider type whatsoever. So any provider is subject to an audit. Prepayment review. Prepayment review basically takes place at the MCO level, but we do have processes in place where we have to approve those prepayments before they are initiated by the MCO. For fee-for-service, we do not do prepayment because we're mostly serving waiver nursing home population. But for the prepayment reviews, we review their information. We have to approve it before they put that prepayment in place. And then post-payment audits, both the MCOs as well as the department conducts post-payment audits. It's, in an effort to identify any fraud, waste, and abuse. We may find, some various things that maybe have not been done appropriately but don't rise to the level of fraud. In those cases, we sometimes identify an overpayment and work with the provider, recoup money from the provider, or come into an agreement with the provider on an amount of money to repay if it's really large, educate the provider. We do a lot of that. And, if it is fraud, then we are going to make a referral to the Office of Inspector General, and that might eventually go, to the Office of Attorney General. The recovery branch basically just collects the money that we identify or that has been identified in a case. So it could be provider or member fraud recovery. It could be, accounts receivable that have been left on the table when a provider has left our network and then they come back in and that money is still there. If they try to come back in or they do come back in, we make efforts to collect that money, work with bankruptcies, services for date after death. Reconciliation of settlements occurs in that branch. They handle the suspension and escrow process, and then we also do some open records. Payment suspension. When there is a credible allegation of fraud, we are required to suspend payment for that provider unless a good cause exception exists, which means that there would be a reason to not suspend that provider. So perhaps there are members that need to be served in that area, and that's the only provider of that type. Then we would not suspend payment at that time. So that's an example of it if there's a health, safety, welfare issue for our members. If the law enforcement exception is requested, then we do not suspend payment until that is lifted. But payment suspension is a way to swiftly stop the flow of our Medicaid dollars from going out the door once we think that there might be a fraud situation going on. And a payment suspension can remain in place throughout the law enforcement investigation and up to the potential prosecution of the healthcare fraud case. The notifications, we do let providers know when we're going to suspend payments. We provide them with certain information and then let them know that it does include appeal rights. Once the investigation is closed, the payment suspension is lifted, and then we make efforts to release the escrow. If there is a settlement in a case, then we determine how we are going to retain and release portions of any money that was held during the payment suspension process, and we work to do that as timely as possible, considering that it might be a complex process with settlement agreements. Just other tools, we kind of talked about codes and things. We also look, tools that we use internally within Medicaid as a whole, prior authorizations, diagnostic criteria, and caps on any type or frequency of services. Monitoring trends, I talked about that a lot at the beginning. It is a collaborative effort. We meet quarterly with all of the MCOs, the U.S. Attorney's Office, the AG's Office, the Inspector General, and we all talk about cases and trends that we see going on so that we're all kept in the loop about what everyone is seeing in the fraud space. And we also partner with MedImpact, our pharmacy benefit manager, because they look at pharmacy first before pharmacy comes to us. And then again, those partnerships we have with health fraud prevention and with our unified program integrity contractor. Third-party liability and state recovery. So that's going to be where members who have another form of insurance are being served, and we are the payer of last resort. So in third-party liability, we make sure that we are the last payer. We prevent dollars from going out the door, and we collect on cases where we have expended dollars that somebody else should have paid for. We go after that money. Same thing with estate recovery. If a member has been in a nursing facility and they have passed away, we try to recover any money that we can through the estate recovery process. Lots of data matches go into this, and in estate recovery, the deceased must be 55 or older at the time of death and in a long-term care facility before we initiate that process. The KI HIP program is another program where we attempt to save as much money as possible. If a member is eligible for an employer-sponsored health insurance program, they will can get covered under that plan, and we pay the premium for them. So we're not paying the claims, we just pay the premium. It saves us a lot of dollars. Here's just an illustration of how much money that we have saved so far in 2025. As you can see, TPL cost avoidance is the highest number, and of course, that's what we want to do, right? We want to prevent the dollars from going out the door first. So we also have a lot of recovery in some other areas, non-commercial, TPL commercial, and then it shows what our recovery for provider and member total is, as well as what we do from our auditing process. So as you can see overall, $251 million plus is what our yearly savings is so far. And then the regulations are here for you if anyone wants to look at those. And then my information is here if you need to reach out to me.
Great. Thank you very much. I appreciate going through that, and I just wanted to compliment y'all for, for the last slide there, about $251 million. I know y'all go through a lot of work. It's not an easy job in terms of juggling what's going on the federal side and working with the MCOs and providers. I understand that. That's very, it's pretty difficult. One thing it's not, and I don't know if this falls under your purview or not, but I didn't see anything in here about outcomes and measurements in regards to, I guess in terms of the providers and the MCOs. A lot of this is back-end back-end processes for audits. Mm-hmm. I know you do some preventive, which is good, mm-hmm. but what is there and what's in there in terms of oversight and making sure the outcomes are being achieved, whatever they might be, not only for the MCOs but also with the providers?
So in terms of the MCOs, they do have to provide us with regular reporting that we go over, which shows the work that they're doing. They have to justify what they're doing. They have to show us what they're doing, what they're recovering. And so we do hold them accountable. We have contract measures that we look at that they have to meet. So we do look to see if the MCOs are meeting their threshold. So, just a few small examples are the number of employees that they have, what those employee qualifications are, how many site visits they perform a year on providers, how many they have to meet certain thresholds. So we monitor that.
I guess in particular, but what in the terms of outcomes, I'm talking about outcomes for the individual client. What are the MCOs doing, and how are you overseeing that in terms of providing? We have particularly when it comes to behavioral health. When you look at somebody who comes in a dire situation, where's your measurements? Where's your outcome in making sure that person is at a higher level, so they can function, so they can be in a better place?
I think that's going to fall more under our MCO oversight branch. They monitor the trends and the health outcomes of our members, and it sounds like that's kind of what you're asking. So that would kind of fall under a different area.
Can you talk?
Yeah, we have implemented this year a value-based purchasing agreement with our managed care organizations, whereby we have a 2% withhold of their capitation payment. We keep those funds until they demonstrate that they have met certain quality measures that we have put in place. For example, we have some maternal health outcomes that they have to meet. We have, there are at least 5 different measures in order to improve the health outcomes of the members that we're serving, because that's why we're here, is to improve the health status of our members. So we do have those value-based purchasing agreements with our managed care organizations. And as Jennifer mentioned, they do provide several reports to us. They have to do a health risk screening, for example, for all of their members to identify individuals who may need case managers, for example. So we do have those oversights. We do also have reporting. They report to us the HEDIS measures on a routine basis, and we can track those HEDIS measures year over year to see if they are improving the quality of care that our members are receiving.
Okay. All right. Good. Thank you very much. The Representative Johnson, you have a question? You have the
Thank you,
floor.
Mr. Chairman. First off, I want to say that I hear good things about how the pharmacy and the PBM program is working in the Medicaid world. So, thank you for that. I would like to just turn to the PBMs, if I could, for just a minute, focus there for a little bit. So, what kind of oversight or contract monitoring activities are taking place with the single PBM contract and also the FFS PBM?
So currently, we do have one single PBM. It's MedImpact. As you recall, Senate Bill 50 from a few years back created one single pharmacy benefit manager for the department, and that includes all of the managed care organizations. So we have one pharmacy benefit manager that is obtained through an RFP, a request for proposal process. We did have a separate fee-for-service pharmacy benefit manager. Again, that has to be procured too. So there are 2 separate contracts, but they are both held by MedImpact. And we do have oversight activities related to the pharmacy benefit manager. We do monitor claims activity. We also have a pharmacy and therapeutics technical advisory committee that oversees some of those functions. They also ask questions. And they have to approve any medications. They submit recommendations for approval to add medications, for example, to the Medicaid benefit. And I'd also like to talk about our technical advisory committees. And we mentioned the Pharmacy Technical Advisory Committee. We have about 18 technical advisory committees, anywhere from physicians to primary care, that also asks for information and help us monitor and oversee some of the activities in the Medicaid program. We also have the Medicaid Advisory Council that serves as the same function. So there are lots of technical advisory committees that have their eyes on the Medicaid program and ask questions. They also make recommendations for improvements in policies and that sort of thing.
Okay, just a couple more. I'm okay.
Yeah, go ahead if you
All
want.
right. So with MCOs and the single PPM program, is there any chance that they're receiving any rebates that are not actually reported to DMS?
I don't believe so, but I'll go double check
Could you look
that.
into
But
that for me?
Medicaid, the way the single pharmacy benefit manager works right now is the MCOs pay an administrative fee to the department for us to administer that contract. The department oversees the contract and is responsible for getting the reporting from Med Impact, and we also garner the rebates. Now, if there are some rebates, maybe the only thing that would be carved out is the physician administered drugs. There are some drugs that are administered in a physician's office that do not come through that single PBM. They come through a different claims process. So there may be a few rebates there, but I will have to double check and confirm that information.
So would you say, with you guys administering the program, you've automatically got a built-in oversight?
Yes, we do.
Would make sense. Is there any? I guess I'd ask what metrics that the single PBM reports to DMS. Have there been any discrepancies, and has DMS taken any corrective actions?
I'll go back and double check, but the Med Impact does report to us the number of medications that are delivered on a routine basis. They also report to us the number of providers, the types of providers. For example, we can give you the top 5 medications, the top 10 medications, either based on the volume of prescriptions or the total spend. So we do have oversight, and we do have reports that we monitor.
Okay, great. Last question. Going to the single PBM format, has that made your life easier or harder?
Well, I think it's definitely helped the providers. It has helped, because prior to going to the single PBM, we had 6 managed care organizations. Each one had their own pharmacy benefit manager, and in addition, there could have been some other third-party vendors within there, and we had each MCO had their own formulary with the medications that were available for our members, and now we have that one single physician drug list, and we have our single pharmacy benefit manager. So it has assisted us in serving our members and our providers in a more efficient manner.
Good to hear. Thank you, Mr. Chairman.
You're welcome. Glad Representative Wilner's back in the saddle, and you have the floor.
Thank you, Mr. Chairman. I'm glad to be back. I'm still hacking away a little bit, but and I've got 2 questions with the chair's indulgence. The first one, I know that there's, I think, a public perception that there's lots of waste, fraud, and abuse in public systems that maybe does not match the reality of the situation. And maybe you've already said this, and I missed it when I was out sick. But I think it could bear repeating. Of the total Medicaid program, what's the scope of the problem of waste, fraud, and abuse, of unrecovered, and any is too much. I do want to say any is too much. These are public dollars used for health of our Kentucky folks. But how big a problem is waste, fraud, and abuse within Kentucky Medicaid?
Within Kentucky.
So within Kentucky, I would say, as far as actual healthcare fraud that's, would go to a conviction, it's relatively small. What we see mostly, not that there's, I don't want to minimize it, but I don't want to relate or make you think that it's rampant, because I don't believe that's true. What typically happens in this space is that there is a trend in a certain area that kind of catches on, and it catches on nationwide. And it's no different here in Kentucky. I work collaboratively with members of program integrity units across the nation, and in my region in particular. And we are all experiencing difficulties with behavioral health right now. So, what is happening across the nation is generally what is happening here as well. And I think it's been well stated that behavioral health has become a challenge for us in many ways, for a lot of different reasons. So I would say there's not an extreme amount across the board, but there are pockets where it occurs. And we learn to anticipate what those pockets are going to be. And then that's, of course, it's, when we find out that there is a gap, then we have to work to close it. And we do that. And I think we're successful in doing that. So then we kind of eliminate that pocket. And then, but there's always going to be something new coming. And so we have to be aware and on top of that. But as far as what we're seeing here, it's in our auditing process, it's not so much fraud as it's some of it is a lack of understanding. Some of it is we have to provide a lot of education. Sometimes it's just careless mistakes that we identify and we're able to collect and recoup because the provider's not done what they should have done. Sometimes it's just a lack of proper documentation. People get lax. So that's what we actually see the most of, if that helps answer your question.
Can you quantify it in terms of a percentage? Or?
I would have to go back and get some numbers, but I can illustrate, what we've seen, like in a certain time frame.
And then earlier this year, in January of 2025, Georgetown University did put out a report related to fraud against Medicaid. And in the report, they do have a statement that says there are no reliable estimates of the amount of fraud against Medicaid, but there are data sources. And so there are some reports from DOJ, HHS, and OIG. I could be more than happy to send a link to this report. It does have links in there, and you can go in and look and see where the most common fraud is. They will have some very specific cases, and as Jennifer mentioned, you can see that once it starts in one area, it spreads across the nation. But it's a very good report on, it's just basically titled The Truth About Fraud Against Medicaid, and it does have links to some very helpful reports.
May I follow up?
Yes, ma'am.
Thank you. And I would love to see that report. I imagine the other committee members would be interested to see that as well. So thank you for that. So the other question I have, and it's, so one of your controls is caps on types and frequency of services. And this is almost like the flip side for me of waste, fraud, and abuse, where people are not able to access the services they need because of limits placed on services by people who maybe don't have the medical knowledge or the behavioral health knowledge and understand what the patient's needs are. I know many of my friends who've worked in community mental health, they see this all the time where a patient may be on the road to recovery, but then there's a cap on services and they're done. They're just told, no more services, or you have to limit this, or no, you can't do this, or you can't do that. And the things that are in the best judgment of the provider, what would help the patient the most, has been denied by Medicaid. And so I'm wondering if you see that as a problem and that maybe we're unnecessarily capping services that really are preventing people from recovering.
And so we definitely could take a look at any of those specific examples. But for children, for example, any child under the age of 21, there's the Early Periodic Screening, Diagnostic, and Treatment Benefit, or the EPSDT benefit. This benefit basically states that children under the age of 21 should receive any service that's medically necessary. So in the event that they are denied the service, they have to go back and look at medical necessity to make sure that that child, and there are no limits. There is no cap or no limits on that EPSDT benefit. We may do some utilization management to make sure that it's an appropriate service. Likewise, for adults, for example, we do have a limit of 20 therapy visits, for example. That includes physical therapy, occupational therapy, speech therapy. In the event that those limits need to be exceeded, there can be a request, and it should go through a peer-to-peer with a physician of like or a similar background to make sure that they are evaluating that case, that service based on a case-by-case basis.
Very helpful. Thank you so much. Thank you, Mr. Chairman.
You're welcome, Representative. I just have I have just a couple questions. I guess when it comes to just one thing about in Medicaid, there's so many acronyms in here, but the external quality review, and I know there's a company that handles quality compliance and so forth. Outside of that, well, I mean, two things. What recommendations have been implemented from those reports? And two, what outside of that, what have y'all done in terms of enforcing these contracts? And I'm going to load up another question for you on that one. I'll give you time to think about that one. There seems to be, at least we've heard, some dispute resolutions and trying to go through that process. And I know there's a scorecard that's been used and so forth. Could you explain, give us a little more background on how you're addressing that, about those two particular items? So I know I loaded a lot of questions on you, but.
That's okay. So the EQRO is our external quality review organization. That is a contract we have with IPRO, Island Peer Review Organization. I can get some of those reports and look at the recommendations they have made, because there are several reports if you're looking for something very specific, but we can get information to you on those reports and the action that we have taken. And I'm not sure I understand the dispute resolution and the scorecard. Is it two different?
Well, there are scorecards that's being used on various particular topics of the MCO's performance and so forth. And I just want to see if you can give the committee just a little of a quick explanation of that, and then what concerns do you have with that scorecard, and then I think within the scorecard, there might be dispute resolutions and how they've addressed those particular issues.
I'll have to take that back. I wasn't prepared to talk about the scorecard today, but I can definitely take it back and get some more information related to the information that is on those scorecards, how we track that. The dispute resolution meetings are typically the dispute resolution meetings that I'm familiar with is in the event that we have, for example, have notified a provider that they owe money to the department. They can dispute that finding, and I'm not know, Jennifer, if you.
Yeah, so dispute resolution meeting to us means that the provider, it's kind of the first step in their like appeal rights process. They can first request a dispute resolution meeting for us to meet informally and discuss, what our findings were, and they can state what their objections are and what they disagree with and provide any additional information. So sometimes we do resolve some issues that way, and cases get kind of, triaged or handled, through that process. If a provider is still not satisfied, then they can move on towards requesting an administrative appeal. So that's what a dispute resolution is. If you're referring to that or something else, I don't know, but typically dispute resolution is based upon some action that we are trying to take on a provider.
Okay. It's more for my edification about that process, and I know some folks have mentioned that to me before, so I'm just trying to get both sides of the issue in that regards. I do have, I guess a follow-up. Let's see if I find I believe Commissioner, and I'm going back to last week. We asked about getting the accounting of the difference on the waiver program between funded and enrolled. Had you come up with that information as of yet?
Oh, so I did take that back to my staff. So the waiver slot, and again, I know the slot is a term that helps us know how many people are enrolled. So those slots that are funded is the total amount that has been funded through the legislators or through the budget process. Those slots that are allocated are slots where people are actually enrolled in the program. Those that are reserved are for individuals who have completed the process. They've come off a waiting list or they've made an application, but their full eligibility has not been determined yet. So those reserved slots are actually slots that we believe that will be filled once that process is completed. For example, we may have to look into some more financial information to make sure that they meet the financial criteria for the waiver, or they may have to go through a level of care assessment. So I do have that verbiage written down, and I can be more than happy to send that to you in an email.
Okay. Well, in the wait list management assessment report, it talks about funded, enrolled, available, reserved, in process, those sorts of things. And even though you explained that, there's still to be some gap. Did I misinterpret that?
I'll have to go back and look at that
Okay.
specific report. I had just asked for the definitions.
Okay.
and-
Could you get back to me to the staff, by Friday on exactly what's going on, because I'm trying to wrestle with a couple of things, and that will help. That will help me out in terms of resolving that.
Okay.
Also, Commissioner, you mentioned, or y'all have testified in the past, and correct me if I'm wrong, for every 1% decrease that the feds might change the FMAP, particularly in the expanded group, It's around $75 million. Was that correct?
I have to go back and double check with my CFO. I thought it was about $50 million for every 1%, but I'll have to double.
Okay, I thought it was 70, but that's fine, 75. And I think the 50 million, what I understand, that's a change in the IT match. I think it's around 90 and 70, and the administration is 5. They're looking at changing that down to 50. I think that's around $50 million. But I never heard, if you look at a traditional Medicaid, when it comes to the feds playing around with that match, and I think we're around 71%. I think you said in the slide. If they go down to say 10%, that's a 10 basis points change. Do you know what it is per point reduction in terms of what that means to our general funds?
I'll definitely go back and get that. I think that we do have some analysis that we have done related to.
And your CFO's told you?
To a decrease. I'd have to go back and look at that report, but we do monitor. We are watching. We know that there may be some policies that come down from the federal level that we will have to comply with, and we are preparing as best we can, but it's just very hard to prepare for the unknown. We know what may happen, but not exactly what will happen for example, in the budget reconciliation process.
Okay. I got another question. I know when I have discussed things on the federal level, they're looking at basically five buckets. Work requirements. Well, I think we've addressed that to a certain degree.
Yes.
You have limit on state provider taxes. You have reduced federal matches. You have per capita cap on expansion population and per capita cap on the entire population. Those things I just mentioned to you before. I know you said you're going to go back, but is there any proactive approach in terms of anticipating from a projection standpoint, but also more important or just as important in terms of the impact on our clients, on our patients? And I know you said slots, and you said last time these are people. And I know and I understand where you're coming from, but I just want to make sure there is a actual human being that we're trying to provide service and get them in a better spot.
So, again, going back to it's very hard to prepare for the unknown. We do know what Medicaid is today. We know what we serve today. We have 1.4 million people in the state of Kentucky. Our budget is, as we saw in 2024, was $18 billion. Any reduction is going to be detrimental to this state. Any reduction. Because the Medicaid budget, as you know, we pay providers. Providers pay their employees. Their employees spend money out in the economy. We are providing a very valuable service to our members, improving their health care. And while we know what could be coming down the pike, it is very, very difficult to be proactive until we know exactly what we're looking at. So we know that the only way to save money in the Medicaid program, there's only a couple of ways. You either have to cut reimbursement to providers, you have to terminate individuals from the Medicaid eligibility rolls, you have to cut services. There's no other way to save money in the Medicaid program. Doing any of that is going to be detrimental to this state and the members that we serve.
No, and I appreciate you're accurate. And those are the 3 items, and I know it's a moving ball, and trying to deal with the feds is mind-boggling sometimes. But one of the things you mentioned in terms of addressing cutting rates to providers. Now, under my understanding, I think in your slide you said that's between the MCOs and the providers.
So currently, Medicaid has a fee schedule. That we use for the fee-for-service population. And we tell our MCOs that they do not have to go by that fee schedule. They can pay more, but they typically contract with their providers. They typically contract with providers for an agreed-upon rate. The Medicaid agency is not part of those contracts. The only thing that we can do is if, for example, an MCO is not abiding by a policy or a regulation or some sort of payment mechanism that is in place, then we can enforce that. But as far as the contract between the managed care organization and that provider, that's between them. So whatever we do at the state level, for example, if and again, just if scenarios because we can't plan, but if we had to cut money from the Medicaid budget, let's say $50 million per year, we would have to sit down and make some very hard decisions about where that money was coming from and look at every single dollar that we're spending, which is what we are doing right now. We're looking not only at our administrative budget, but at our benefits, at our provider rates. And as you can see, we, in 2025, $250 million in fraud and abuse or recoveries. That's not going to touch $50 million in state funds if we have to do that a year. So it's just going to have to be an ongoing conversation and a partnership to make sure that we're doing the best thing we can for the Commonwealth of Kentucky.
Yeah. And I appreciate that. I know it's a daunting task to go through that. And we want to look at this as a partnership with you all to make sure that that we address the needs of our community and those who are least among us. And so that's what we're trying to accomplish. I want to see if there's any other questions from the members. Very good. Okay. Well, thank you all very much, Director and Commissioner. Thank you very much for coming in and making the presentation. I'm sorry we got you sort of truncate and go through that process, but it's a big process. It's a big things. We got a lot of things in front of us, and we're going to be really challenged. So we really need to look at some partnerships that going forward with that. So with that, thank you very much. And if there's a motion for adjournment, I'll accept that.
Move for adjournment.
We stand